Okay, good afternoon, everybody. I'm Theodore Friedman. We will be talking about hair loss in women today. Thanks, everybody, for joining. And I will mute everybody's phones. Please use the chat button at the end for questions. Alopecia is the medical term for excessive or abnormal hair loss. Hair loss may also be a symptom of a short-term event such as stress, pregnancy, and the taking of certain medications. In these situations, hair will often, though not always, grow back when the event has passed. Substances such as hormones, medications, and diseases can cause a change in hair growth, shedding phases, and in their durations. When this happens, thickness, growth, and shedding occur. Once the cause is dealt with, many times hairs will go back to their normal random pattern of growth and shedding, and the hair problem stops. This is the stages of hair growth. You have the anagen stage, which is the growing stage, and the hair follicle grows deep for nourishment. It gets oil from the sebaceous gland. The catagen stage is the resting stage. And the hair follicle shrinks, the hair detached from blood supply, the patella breaks away and becomes inactive. The telogen stage is when most of the hair loss occurs. It's a shedding stage, and this is where the hair fibers are easily pulled out. The affected hair follicle will reduce in width until it is no longer sustainable and the hair falls out. So you have a balance between hair growth in the anagen stage, hair loss in the telogen stage, and then the hair returns to the anagen stage. A longer time in the telogen phase and delayed entry into the anagen phase leads to hair loss. The most common type of hair loss in females is called female pattern baldness, or female pattern hair loss, abbreviated as FPHL. It's also known as female androgenic alopecia. It primarily affects the top and front of the scalp, such as giving a bald spot on the crown. Approximately 40% of women in some stage of their life suffer from hair loss, and hair loss in women can be absolutely devastating for the sufferer's self-image. The person often feels unattractive, and it affects the emotional well-being. Hereditary, often on the father's side, plays a major factor in the disease, and if both parents of the woman carry the hair loss gene, it's quite likely she will have female pattern hair loss. Androgens, and I'll talk about this extensively, such as testosterone and DHT, dihydrotestosterone, play an important role in hair loss. Thyroid problems, low iron stores, or low ferritin, stress, and menopause are very important in female pattern baldness. Estrogen helps hair grow faster and stay in the head for a longer duration, leading to thicker, healthier hair, and it is well known that pregnant women usually have superb hair during their pregnancies. So menopause, when the estrogen levels drop, it's a time for worsening hair loss frequently. There are three stages of hair loss: thinning hair, hair loss, and baldness. And we want to prevent the last and the baldness. A female with hair loss will notice a diffuse thinning of her hair across the entirety of her scalp initially. This is followed by the development of a bald patch running from the front of her scalp in quite a straight line to the back of her head as if following the line of a central parting. This is, again, sort of the more severe case. And this time, in time, the bald line will expand to the left and right until she eventually becomes bald. There's some pictures I got from the internet of female pattern hair loss. There's this hairline over here. Here's a person with pretty diffuse hair on the top of her head. Here's a view from the top of female pattern hair loss. The more serious disease is called alopecia areata. It's an autoimmune disease that causes hair to fall out in small, random patches, like this one over here. The hair loss usually affects the scalp, but can occur also in other areas of the body. And this develops when the immune system attacks the hair follicle, resulting in hair loss. So this is an autoimmune condition. There's different types of this. Diffuse alopecia areata. The hair may be lost more diffusely over the whole scalp rather than in one specific area. Alopecia totalis is when there's a total loss of hair on the scalp, and alopecia universalis, which is loss of the hair over the entire body. There's also a condition, alopecia barbae, loss of hair on the beard. We're not going to talk about male loss today, but interesting, this has been identified as the biblical netzek condition. that is part of the diseases I mentioned in the Torah and the Bible called Saras, family of skin disorders, and this is discussed in the book of Leviticus, chapter 13. So alopecia areata has been around a long time. Alopecia areata is an autoimmune disease that develops when the immune system mistakes healthy cells for foreign substances. Normally, the immune system defends your body against foreign invaders such as viruses and bacteria. If you have alopecia areata, however, your immune system mistakenly attacks your own hair follicles. Hair follicles are the structures from which the hair grows. So in alopecia areata, the follicles become smaller and stop producing hair, leading to hair loss. Alopecia areata most often occurs in people who have a personal or a family history of other autoimmune diseases, such as Hashimoto's hypothyroidism, Graves' disease, Addison's disease, type 1 diabetes, lupus, or rheumatoid arthritis, and it's part of a condition called polyglandular autoimmune disease type 1, where the patients have frequently autoimmune thyroid disease and Addison's disease, among other conditions. In alopecia areata, the hair may grow back at any time and then it may fall off again, so it is somewhat random, the course of it. A scalp biopsy can be used to diagnose alopecia areata. And often it's hard to distinguish this from the female pattern baldness, androgenic alopecia that we mentioned earlier. The skin biopsy may be needed for that, although in alopecia areata it's more patchy and more extensive hair loss. Looking for other autoimmune diseases is often helpful, such as, again, Hashimoto's hypothyroidism, Graves' disease, Addison's disease, and type 1 diabetes. In cases of alopecia areata, hair will tend to pull out more easily along the edge of the patch where the follicles are already being attacked by the body's immune system, then away from the patch where they're still healthy. Unfortunately, there's no specific treatment for alopecia areata. The hair has what's called exclamation point hairs. They're narrower along the length of the strand closer to the base, producing this exclamation point appearance that is seen in this picture here, that this is the base and sort of narrow here and then becomes wider farther away from the base. There's another condition that seems to be a little bit harder to describe, and it's a little bit vaguer as distinction. It's called alopecia areata incognita. It may or may not be the same as the alopecia areata. It seems a little controversial about that. It's a rare form of alopecia. It's also controversial whether alopecia areata incognita occurs primarily in young women, as I saw one article, but however, other articles seem to say it's not the case. And in alopecia areata incognita, the typical patchy distribution of hair loss in classic alopecia areata is absent, but there's abrupt and intense hair loss is characteristic. So rapid hair loss, but not necessarily the patchy distribution of alopecia, regular alopecia areata. There's another condition called telogen effluvium. This is when the body goes through something traumatic like childbirth, malnutrition, infection, surgery, extreme stress. The hair in the anagen or growing phase or the catagen, the resting phase, can shift all at once into the shedding telogen phase. About 6 weeks to 3 months after the stressful event is usually when the phenomenon of telogenic effluvium begins. And you can lose a lot of hair during this time during full-blown telogen effluvium. For most people with telogen effluvium, there is a remission once the stress event has passed, and as long as other stress events can be avoided. Another condition is called anagen effluvium. This occurs as an insult to the hair follicle that impairs its ability to divide, the mitotic or the metabolic activity. This is what is associated with chemotherapy. Since chemotherapy targets your body's rapidly dividing cancer cells, your body's other rapidly dividing cells, such as hair follicles in the anagenic phase, are also greatly affected. Soon after chemotherapy begins, approximately 90% or more of the hairs can fall out while still in the anagen phase. The characteristic findings in the anagen effluvium is the tapered fracture of the hair follicle shafts. Eventually, the shafts narrow, the shaft fractures at the site of narrowing and causes the loss of hair. So who needs a scalp biopsy? These are usually done by dermatologists, not endocrinologists. And from my reading of the literature, this is very helpful to distinguish between androgenic areata and alopecia areata. It can be used to determine other causes of hair loss, including fungal infections such as tinea capitis. Usually a very small section of the scalp, 4 millimeters of diameter, is removed and examined under a microscope at a lab or in the office to determine the cause of hair loss. The hair pull test can be done by anybody. It's a simple diagnostic test in which the physician pulls a small amount of hair, approximately 100 hairs, and in order to determine if there's an excess loss. Normal range is 1 to 3 hairs per pull. So if you pull gently on the hair and a lot of it comes out, this is consistent with a positive hair test, consistent with both androgenic areata or alopecia areata. Now, as you know, I'm an endocrinologist, so I'm especially interested in hair hormones and hair loss. The hormones that are involved, the hormone conditions, are mostly hypothyroidism. This is especially in Hashimoto's hypothyroidism when you have the positive TPO antibody. In hyperthyroidism, you get hair loss. Fluctuating thyroid levels, if you're rapidly going from hyper to hypo and then back again to hyper, that can certainly lead to hair loss. Cushing's disease can give you hair loss. Growth hormone deficiency. High testosterone, another hormone made by the adrenals called DHES being high, and high of a metabolite of testosterone called dihydrotestosterone can often give you hair loss, especially the androgenic type of hair loss. These occur in polycystic ovarian syndrome, PCOS, and also in a condition called congenital adrenal hyperplasia, where you get excess androgen buildup. Sorry, that's not insufficiency, that's hyperplasia. Too much progesterone can give you hair loss. Progesterone has the androgenic properties. Hyperlactin can give you hair loss. Low estrogen can give hair loss, and iron deficiency, as manifested by low ferritin, can give you hair loss. Now, what about testosterone and androgens? Testosterone shrinks the hair follicles, causing hair loss on the head, yet greater production of facial hair. So it's a paradox that the hair on the top of the head falls off, but the facial hair increases. Testosterone converts to dihydrotestosterone due to an enzyme called type 2 5-alpha reductase, which is in the hair follicle's oil glands. In addition to the circulating testosterone or bioavailable testosterone or free testosterone levels, the level of the DHT binding to receptors in scalp follicles is a problem. DHT also shrinks hair follicles, making it impossible for healthy hair to survive. Some women's hair follicles are very sensitive to DHT. DHT binds the hair follicles and forces them to go into their resting phase or telogenic phase sooner than is normal. This means that new hairs grow thinner with each cycle of hair growth. So the good hormones for hair are high levels of estrogen and high growth hormone. And what I would and then the bad hormones are the testosterone, DHES, DHT, and fluctuating levels of thyroid. So what test I recommend would be the bioavailable and total testosterone levels. So these are serum levels, estradiol levels, especially usually get them on day 3 of the cycle when it's fairly stable. IGF-1 is a test for growth hormone deficiency. Free T4, free T3, TSH, TPO antibody, the marker for Hashimoto's, and sometimes you can get the reverse T3, which sometimes blocks the action of free T3, and maybe if that's excessively high, can give you some hair loss. Ferritin, which is a very accurate way of testing iron stores, is very good to get. I usually get an IGF-1 to look for growth hormone deficiency. I would do tests for Cushing's disease if indicated. I test for congenital adrenal hyperplasia with a 17-hydroxyprogesterone if the patient has other signs of androgens and if it's in the person's profile. And celiac testing can be done. There's some link between celiac testing, positive celiac testing, and hair loss. So what I do for treatment for hair loss, I try to optimize thyroid hormones, treat the growth hormone deficiency, treat low ferritin. That's somewhat easy to do with iron, and there's now an iron patch that's available. Try to target a ferritin level above 70. I usually give estrogen either in the form of a patch or a gel. I target an estradiol level of about 50 to 100. And if the person does indeed have true celiac disease, they put them on a gluten-free diet, and that can help their hair. Many patients do have high testosterone that's involved in their hair loss. I usually mostly look at the bioavailable testosterone, which is the active form of testosterone. The assay is quite good. And I usually a level of greater than 8, consistent with high testosterone, and also sometimes a DHES greater than 250. If these are high, I try to lower them. The different drugs I use to lower testosterone include metformin, flutamide, which blocks testosterone receptors and also decreases its production. Spironolactone, which does also block testosterone and reduces production, but also blocks aldosterone. A supplement called inositol, which is made of different types of inositol. Resveratrol, which is a supplement that is very good at lowering testosterone, so they'll lower the counter. Everybody please mute your phone. Omega-3s can lower testosterone, and acetylcysteine can reduce your testosterone. And I did a webinar a couple months ago with Angela Grassi, I think it was in January, where we discussed completely the treatment for PCOS and high testosterone, including supplements, and I recommend people listening to that webinar if you have some questions about what to take to lower testosterone. The DHT, again, is the metabolite of testosterone. Certainly if it's high, it's worth lowering it. I find it's rare in female patients. I use a cutoff of, say, 20 nanograms per deciliter, which is near the top of the range for a female. And you can use the drug finasteride, which is also called Proscar or Propecia. It works well in men, not so good in females. Most studies have been negative, have not found this drug to be helpful. In larger studies, there are case reports to show it has some effect. This drug cannot be used in pregnancy. There are a lot of drugs that give you hair loss, and I think it's important to look at these drugs and try to eliminate them if possible. Some of the drugs, this is not a complete list, include Accutane, anticoagulants like warfarin, Coumadin, blood thinners, cholesterol drugs, for example, Lipitor gives you hair loss, but not Crestor. Antidepressant drugs, pretty much all of them can give you hair loss, sertraline and Prozac, Wellbutrin. All these drugs can give you some amount of hair loss, and it's not, it is different between different drugs. You can be on one antidepressant that gives you hair loss and switch to a different one, and your hair might be okay on a different one. Amphetamines such as Ritalin and Adderall can give you hair loss. Some antifungals, but not the medicine ketoconazole. Ketoconazole usually lowers testosterone. It's helpful for hair. Beta blockers used in cardiac conditions and blood pressure control. Non-steroidal anti-inflammatory drugs such as Motrin and other non-steroidals can do this. Methotrexate, which is a drug used for lupus and other autoimmune diseases. One of the main culprits I see is prednisone and other types of steroids. Prednisone is given widely for a lot of conditions, and this is one of the worst drugs for hair. Even though it modifies the immune system, it still can give you hair loss. Injections of glucocorticoids for back pain and things like that can also do it. They can accumulate. So I really watch drugs like prednisone. Birth control pills usually have high progesterone and low estrogen, and there's different categorizations of birth control pills. The high estrogen and the high androgen ones are the ones to watch out the most. Desogen is the lowest androgen birth control pill, and low estrogen is the highest androgenic birth control pill. These are the ones that are on this list. Progesterones are also notoriously for giving hair loss. They have androgenic properties. Depo-Provera and Norplant, the Norplant implant, both of them give high progesterone levels for a long period of time and are often culprits for hair loss. Pretty much all forms of testosterone given to a woman can be dangerous. If a male is putting on androgel and it rubs off on a female, that can also lead to high testosterone and lead to drug-induced hair loss. And any type of DHEA can give you hair loss as well. So what are the different types of treatments besides optimizing the hormones? The ones that include are minoxidil. The 2% is FDA approved in women. There's a 5% one that's not FDA approved for women. Doesn't really work that well, but it's often can be done, can be tried. Another old drug that I think works pretty well that's not really used that much for this, but really is a good choice to try, is Tagamet. The generic name is cimetidine. It's used to treat gastrointestinal ulcers. It has anti-androgen effects, and it blocks DHT from binding to the hair follicle receptor sites. Somehow also the acid in the stomach seems to play some kind of role in it that's different from the other antacids. So this drug works reasonably well. You can take up to 5 of the 300 milligram pills per day. Nizoral is a shampoo that contains 2% ketoconazole. It has antifungal properties and may reduce DHT locally. Topical steroids rubbed on the head, including clobetasol or fluoxetine creams, work somewhat. They take a long time to see results and moderately effective. Steroid injections into the scalp can be used, especially when the area is small. The hair loss area on the head is small. Elicon, which is also called mometasone ointment, can be used. Irritants such as anthraline and topical coal tar and topical immunotherapy rarely can be used, cyclosporin. These are generally given by dermatologists, so if you want these, probably not the right person to see, probably need to see a dermatologist. There are reports of nutritional deficiencies being associated with hair loss: iron, zinc, selenium, and biotin. You can measure these. Again, the iron is the most common one, giving you low ferritin. Zinc, selenium, and biotin, I think, are less likely, but can be looked at if you desire. The treatments. In general, my reading of the literature is androgenic alopecia is more likely to get better than alopecia areata. I've seen some patients that their doctors recommended immune therapy. These are different type of drugs used for lupus, for example. I think they're unlikely to work in alopecia areata, and they have a lot of side effects. I am intrigued by low-dose naltrexone and have a few patients on that. We'll see how that works. Low-dose naltrexone is used as an immune modifier. It has pretty little side effects, and it is a possibility to try in patients with especially the autoimmune type of hair loss. In general, treatments are likely to be modest and do take a long time, but they're often effective. And the earlier the hair loss is caught and the more mild it is, the better the outcome. And I recommend to optimize your hair with the best hairstyle, try to make it look styled nice, extensions people use, and wigs. And I want to mention a type of wig called a shaitel. I'm not sure I spelled that right. These are wigs that Orthodox women wear. They're usually very elegantly made and often can be expensive, but they really look very nice. And if you want to get a nice wig, you should go to a Jewish neighborhood, especially in probably Brooklyn. There's plenty of them. There's some in Los Angeles, and get one from one of the Jewish wig stores and probably not a regular wig store. The lifestyle changes have been suggested, certainly no proof on this. Avoid crazy diet fads that may throw your hormone into a tizzy. Hair is protein, so consuming protein-rich foods along with essential fatty acids, iron, vitamin D, and E are all healthy hair options. And exercise it certainly can't hurt. It may help your hormonal balances, decrease your stress a little bit, and decrease your cortisol. And this may be helpful, although certainly it's not been proven. Stress reduction, again, is a good idea. The high cortisol from stress probably plays a role in hair loss. Chronic stress can lead to hair loss if stress moves the hair out of the growth or resting stage into the shedding stage of the hair cycle early. You can do things like yoga, Pilates, meditate, and avoid conflicts. I always recommend that. Poor sleep habits can worsen stress and make it more difficult to cope with. And the National Sleep Foundation recommends at least 7 to 9 hours of sleep per night for adults 18 or older. Different foods that promote hair loss include protein, liver, brewer's yeast, fish, eggs, beans, cottage cheese, yogurt, and tofu. Iron-containing foods, liver, whole grain cereals, dark leafy green vegetables, eggs, dates, and raisins. Vitamin D, you can drink fortified orange juice. Not sure that would be my top choice for getting vitamin D into you. Essential fatty acids such as walnuts, canola oil of fish, and soy. And vitamin E, you can either take a supplement, although again, those studies really have shown it works. And you can eat avocados, nuts, seeds, and olive oil that often have pretty high levels of vitamin E. Now, supplements. This is, again, a controversial area with little literature on it. Americans spend almost $1 billion per year on hair loss treatments. According to the American Hair Loss Society, 90% of the treatments are unfortunately ineffective. I think the one that's used mostly is biotin. High doses of biotin have been shown to affect thyroid testing. The doses that are commonly used probably don't. Biotin is a water-soluble vitamin. It's part of the vitamin B family. It's often called vitamin B7 or vitamin H. It's popular, but I could not find any clinical studies. I looked at a couple of reviews on it, and they stress that there's no clinical studies. Another supplement that you see advertised a lot is called Viviscal. It's oral marine protein supplement. It contains shark and mollusk powder derived from sustainable marine sources, which provides essential nutrients to nourish hair naturally and improve the appearance of thinning hair. And there has been some studies showing that this is helpful compared to placebo in hair loss restoration. Other supplements that I've seen that, again, very little literature on this. A lot of my patients like betaine, hydrochloride pepsin. It treats low acid stomach, which may play a role in hair loss. We always give people these PPIs to lower their stomach acid that might be detrimental in hair loss. A lot of patients seem to say this seems to work pretty well. There's phytoestrogenic herbs such as ginseng or black cohosh that contain estrogenic compounds produced by plants that help get your estradiol level up. And there's the one that's widely touted on the internet called Macafem that has this radish-like root called Lipodium mayeni, and it has a high concentration of nutrients that are supposed to help with hair. So my approach to hair loss in women overall is to optimize thyroid hormones, lower bioavailable and total testosterone, remove the culprit medicines, treat growth hormone deficiency, treat low ferritin and target levels around 70, give estrogen, try to target estradiol level of 50 to 100. And you can try a supplement one at a time to see if it helps, and if it doesn't help, stop it and go on to the next one if you are so inclined. Okay, so we can open up this to questions now. We'll use the chat button on the program. If you have any questions tonight, email us, or you can say happy to see you in my Los Angeles clinic if you live nearby or want to come visit LA to optimize your hormones. And I will post the webinar on goodhormonehealth.com in the next couple of days or so. So let me open this up to the questions. We'll do the chat button here. Please feel free to send a question on the chat button. Hi, Mary. Is DHT included in your typical testosterone testing, or is it a special DHT test? It's not included. You have to specifically order that. And, you know, again, if there's a concern, especially if your testosterone is high, I think getting the DHT test is appropriate. Mary says she's 1.5 years post-pituitary surgery. In general, most patients that have hypopituitarism would have low testosterone and low DHT. So my guess is this is probably not a culprit. However, the growth hormone deficiency, estrogen, and low estrogen would be more likely a culprit in Mary. Okay, Vicky says, worried about taking estradiol without progesterone, can you get estrogen dominant? So you do need progesterone without estrogen when you take estrogen, otherwise you get buildup of the endometrial uterus. But you could take a sort of a low dose of progesterone and take it once every 3 months, for example, or have your gynecologist do ultrasounds of your uterus to make sure your endometrial lining doesn't get too thick. All those are options to try to minimize the effect of progesterone, and not everybody has the detrimental effects of progesterone. So you can try some progesterone, especially progesterone cream. It's probably a little lower dose than the oral progesterone. Mary asked, I saw improvements with hair loss after surgery, but now I'm 5 months pregnant and hair loss. And it's happened again. Hair loss has happened again. Um, most women do better during pregnancy. Usually the estrogen in pregnancy does help, but I'd certainly recommend checking your ferritin level and optimizing your iron, checking your thyroid test, and optimizing that. Since you are hypopit, I doubt you have testosterone. Lisa Lee asked, could you take marine supplements if you're allergic to shellfish? I would probably not take that if you're allergic. Marie Prudence says, I'm taking 6 milligrams 16 pack for back pain, just started. One-time use cause hair loss. Again, I'm not crazy about this. Steroid, Metro packs have high doses steroids. I would probably, if any way you can avoid it, you can. But if you do take it as short a period of time as you can and get off it, and hopefully you'll be okay. A short pack of Medrol probably won't give you worsening your osteopenia, but it certainly is not better for it. It's not good for it. Mary Stonebridge asks again, I'm getting a bunch of hormones tested, DHEA, testosterone, androstenedione, prolactin, FSH, LH, and progesterone. Those all sound good. I would probably get in addition to the regular testosterone, make sure you get a bioavailable testosterone that shows the active hormone. Moxie Melissa says, hi, Dr. F. This is Melissa from Texas, but live in Los Angeles. Hi, Melissa. Where to go? I'm a BLA'er. My hair is falling out lately. I'm taking 600 milligrams of progesterone. What is the level you look at in labs? I think 600 milligrams, if you need it for a short period of time is okay, but it probably is a culprit in you. You can measure your progesterone and see levels shouldn't be too high, but I would probably consider cutting that down. I think we did that short term on you, but now that hopefully your bleeding stops, just try to cut that down. Mary asked, should I be mainly concerned with my estrogen and progesterone levels? I think that would be certainly a good thing to look at. Lisa says, can you take marine supplements related to shellfish? I would probably avoid that. Vicky wants the article on ferritin and hair loss. It's on my website for anybody who wants to see it. Well, let me take that back. So in my article on ferritin, I mentioned that. I don't think there's that many actual studies on ferritin and hair loss, but I think it's pretty well accepted about ferritin and hair loss. I can look in literature to see if I can find anything. Melissa again says, so again, ferritin is maybe, there's certainly an article on fatigue and ferritin levels, but ferritin and hair loss, I think it's fairly accepted without that much studies on it. Melissa asked, BLA'er, I take DHEA, increased it from 25 to 50. What is the target range from DHES? You want to look at the levels for your age, but you should be probably nearer the middle to lower part if you have hair loss. 50 is a pretty high dose. Many of my patients on 50 do get acne, greasy hair, extra facial hair. I would probably cut it down to 25 unless you had a big improvement on the 50. Janet asks, is it possible to have normal bioavailable testosterone, high DHT? I think it's pretty unlikely. Most of the patients I see have high bioavailable and pretty normal DHT, but we can check that in people and see. I don't check DHT that much, but I think maybe we should do it more. Lisa asks, if you're already having hair loss and low estrogen, possibly low human growth hormone, low testosterone, would taking low dose of testosterone make the hair loss worse? I think that's a good question. I would probably be cautious about that. I would supplement only up to certainly no more than a mid-range of testosterone. And it sort of depends on how much your other symptoms like low libido and muscle strength are important, how much we can optimize your other hormones. But I would be cautious in terms of the supplementing the testosterone. Liz asks, How much progesterone should one take over the age of 50 of hypopit? How much is too much? Most people, I give 100 milligrams of progesterone or prometrium every night. Some people, I would give that every 3 months if they have symptoms of it, every 3 months for 10 days or so. But most people do okay on the 100 milligrams at night. And you have to follow the patient, see how they do. You can check labs on progesterone levels. Marie says, thank you for doing this video. Dr. Friedman, is estrogen replacement recommended for postmenopausal women? I think every woman is individualized and sort of depends on how postmenopausal you are. But me and I think many people do put menopausal women on estrogen, especially sort of more at the time of estrogen, especially if they're having symptoms, hot flashes and vaginal dryness. But I think hair loss could be a reason to put somebody on it, as the hair is often does get better with the estrogen. You know, and the risks are things like blood clots, strokes. It's usually pretty negligible. Breast cancer, it's usually very uncommon if you take it in your 50s. When you start getting into your 60s, I would say the risks of estrogen are become higher and the benefits become less. Becca says, is hair loss caused by active Cushing's? What is the best way? If the hair loss is caused by active Cushing's, what is the best way to treat it? Try to lower the cortisol is the best thing to do if you can. Otherwise, I think you need to optimize all the other hormones as best as you can, thyroid, for example, iron, things like that. Lisa Lee says, if you use steroids 3 years ago, that could cause a buildup in your system since stopping steroids and continue to cause hair loss. I think by 3 years it should be out of your system. I would say that's unlikely to be a problem. When do you know if you should have your DHT tested? You know, I think if you're taking, if your testosterone's high, you can get it done. I think if you're thinking about other options, including the finasteride for it, I think it would be reasonable to do. Melissa says, I'm currently not currently on estradiol patch. Used to be taking no extra hair loss. Yes, I think so. I mean, I think you're on a high dose progesterone with no estrogen. I think that's a setup for hair loss. But she doesn't have acne or facial hair, greasy skin on the DHA, so that's probably a good sign. Kelly asked, after an adjustment and replacements, I've noticed a change in, I presume she means thyroid replacements. I noticed a change in hair several times. It's important to mention some of the less dramatic changes. At what point should we mention it? You know, try to make gradual changes. Try to keep your thyroid levels pretty constant. Mention it to your doctor. Mention it to me if you're getting this, and we can try to optimize things if need be. Melissa says, love these talks. Good to hear your voice. Thanks, Melissa. Miss you. Liz says, if you are hypopit, can you be on estrogen and progesterone after menopause? Definitely. So a hypopit patient probably needs estrogen and progesterone more than a regular menopausal woman because they had many years of having low estrogen and progesterone, which you know, could have certainly damaged their bones. They're probably, on the other hand, maybe they're having less symptoms because their body's used to it for years. But I would say they would be good candidates for estrogen and progesterone replacements. Melissa says, I'm taking prednisolone 5 milligrams from L 3.5 a day. Really works for you. Great job. Good, Melissa. That's a good choice. How do I bring progesterone on? Can I gradually drop to from 600 to 200 or do it gradually? I would do it gradually, going on to 400 for about 2 weeks and down to 200 in about 2 weeks. See how that happens if you're bleeding. Tricia says, I'm a sickle of Cushing's, but of course, rather than get the official diagnosis by UCLA, my hair loss continues, comes out acute, chronic, when shredding. I can, something with the hair length and shortness of breath, and DVD affinity, then SNAP with little effort. I'm not on any meds. Yeah, I would get your testosterone checked, ferritin, thyroids, all those checked and optimized. Try to get your diagnosis of Cushing's, and of course, I'm happy to see you get you diagnosed quick. Thank you, Melissa. Your best periods of regular 35 days. That's a good sign. Again, maybe you can get off the progesterone. What dose of biotin do you recommend? I'm not really sure the different doses. I think different manufacturers have different concentrations. But you know, you can get something from a reliable place and take what they recommend. The hair has its crazy texture foreign to me. Texture seems to also be hormonal issues related to that. So again, get all your hormones checked. Tricia says, we'll call and make an appointment. Thanks. Sounds good. I can unmute the phones. I think I can. And we can try to take some calls in case someone's on the call. I think I can. Nope, I guess we got to continue on the chat room chatting. How does DHEA play a role in hair loss? DHEA is also a crucial hormone for hair, similar to testosterone. It binds to the testosterone receptor and basically acts like testosterone. Many things that lower testosterone lower DHEA, but sometimes it's harder to lower it. Metformin can be used. Resveratrol, as the studies have been shown, has lowers DHEA. So it's sort of similar to testosterone. Moxie, Melissa, yes, hair is frizzy. Why does straight hair go curly for Cushing's patients and curly hair go straight during the Cushing's experience? What happens to hair? It's a good question. I'm not sure there's been, unfortunately, too much studies on hair and Cushing's, at least from a microscopic level. But I see a lot of certainly hair loss in Cushing's patients. Marie asks, with removal of my stress, my hair is growing back very finely. This will change. Well, I'm really glad that it's growing back. And I think finally is a start. And I think after a while it gets a little bit more coarser. Is there a notable regrowth of hair after cure for Cushing's in your patients? Yes, definitely. Hair gets better in most patients that Cushing's is cured. This hair is unruly and unmanageable, just like Cushing's. Got to get everything optimized, cut down on your progesterone. I have a hormone question, a hair loss question. Can you have hot flashes with normal estrogen and progesterone levels? Possibly. So, you know, the range of estrogen and progesterone are both pretty wide. You know, for different people, you may need to be at the top of the range for estrogen, for example, to not get the hot flashes. It's also somewhat if you're used to a certain estrogen level, all of a sudden it drops, you know, let's say you're used to a level of 150 and it goes down to 75, which is in the middle of range, that might be enough to give somebody hair loss. Can you talk about stomach acid and how it relates to hair loss? I'm curious about the betaine pepsin supplements. I did look on an internet site about this. I'm not sure how super reliable it is. But at least this one website said that the low acidity normal acidity and not low acidity is bad for hair. So the beta the pepsin hydrochloride lowers your acidity, which may be helpful. However, you know, you have a lot of people on these PPIs that don't have that have a very neutral stomach. PPIs are one of the most common drugs used, and I don't see a huge amount of hair loss with it. But you know, maybe there's other things in the Pepsid that seems to help with it. Okay, I've unmuted everybody. If anybody's on the phone that tried to call in, that called in and wants to ask a question, try to keep your if you're not talking, mute your phone. But anybody who's on the call wants to ask a question.
I have a question.
Uh-huh.
It's Michelle Mangione.
Hi, Michelle.
Hi. Can stress really lead to hair loss?
It certainly doesn't help. I looked a little bit on some articles on that also, and there was some studies that looked at people with stress, and there wasn't that much. Most people's experience is it does make it worse. It certainly leads to that telogium effluvium condition. I think, as I always joke around, it's hard to find people without stress, so it's hard to do any studies. But I would probably try to minimize stress.
Okay. Thank you.
Liz asked, Melissa asked, when's the next chat? I don't know. I have to think of a topic, but I got several on my mind. We'll probably have it in a month or two. If anyone wants to chat me, send a chat request for another topic, we can think about that. Do certain thyroid hormones cause more hair loss than others? That's a good question. So I think you need a balance of hormones. I think that people that, you know, T3 is the active hormone, so you certainly don't want the T3 to be too low. T4 is the storage hormone, so you want that to be in pretty good shape too. There's some, and I may do a webinar on my thoughts on reverse T3 coming up. I think people with a pretty high reverse T3, it may block the T3 from binding, and that may be bad too. I'm not sure about everybody, but that may be something to consider also. So I think you really want everything optimized the best they can. Some people do fine on T4 and it helps their hair, you know. So Melissa wants to talk on reverse T3. Okay, I'll try to pull something together on that. I might also do an article for a newsletter. Oh, Melissa wants life after BLA. I could do that. I don't think I have that many patients with life after BLA. We could talk about something about Cushing's. We haven't talked about Cushing's in a while. We can talk about, you know, post-op Cushing's in general. Cyclical Cushing's. Trisha's doc poo-poos it. Well, I published an article in Hormone and Metabolic Research about 6 years ago where I took 55 consecutive patients and measured several UFCs and salivary cortisols. 51 of the 55 that ended up having Cushing's had at least one normal value among their highs. So I don't see how you can prove Cushing's with that data. Final questions? Is there another thyroid medicine you recommend versus using synthetic kind made from pigs? Well, is an alternative available. So the difference desiccated thyroid, everything is made like in vats, but the desiccated thyroid comes from pigs, like Armour and W2 thyroid. That's an option. Synthetic ones, or T4 and T3, are certainly options. There is somewhere you can get a sheep one if you have religious preference for that, such as somebody keeps halal. My rabbi certainly said that you could take Armour thyroid from pigs because you're not in terms of issues of kosher, because you're swallowing it. But we could talk about that for you, Lisa, where you want to go on. Melissa wants to do a genetic cause of Cushing's. I have that talk. I can give that. We gave that at the, it's a good idea. We gave that at the pituitary meeting last summer, at the Magic Foundation meeting last summer, genetic cause of Cushing's. How menopause, Dana asked, how menopause screws up the entire endocrine system, and why don't doctors know thyroid cortisol is affected by menopause? We gave one on menopause. You should look on my website on that one. I think about 9 months ago. I think we did it. We did it with the other doctor from Washington D.C. That was a good one. I think go look on my website for that one. With chats are on my first page on the left side of my website. Maybe I'll do another one on that, but that was a really good one. Liz asked, how do you treat Hashimoto's and central hypothyroidism at the same time? You optimize both the free T4 or free T3. You usually will get a low TSH in central hypothyroidism, so you don't want to have, if that you're on too little medicine if your TSH is normal. Usually you have to have a low TSH if you have central hypothyroidism. I was asking about thyroid from husband and thyroid damage from chemotherapy. So chemotherapy certainly gives you hair loss, and it can damage your thyroid. Certainly radiation to the chest area can damage the thyroid, radiation to your head, pituitary. Whoever is typing, please mute your phone, your computer. And so that person certainly needs the thyroid checked, and the chemotherapy, I don't think there's anything for that. You just have to wait till the chemotherapy wears off. Do you see any patients that have had dry eyes for low estrogen? Yeah, a little bit. Not that much, but I think occasionally, and I think it's worth it if you have dry eyes to optimize your estrogen. I think there may be certain forms of Cushing's that have not been discovered yet. I think so, but we haven't discovered them yet, so I don't know. I think there's more recognition of this episodic Cushing's by more people. Thanks for taking the time to do these webinars. They're so helpful. I'm out. Thanks, Mary. Okay, why don't we finish here? Here's one more from Sonia. I found my hair loss rather interesting. The loss is more prevalent to a man going bald, the top of the head over the crown, but slightly above the ears. Is there a medical term that describes this loss? That's sort of an interesting question. So the articles I read try to distinguish between male and female pattern hair loss, and they try to seem to say that males get male pattern, females get female pattern. But I'm not sure that's true. And I did try to stick with what I read, but I think that females can get a male pattern baldness, and it's probably due to the high testosterone and DHT. Tricia says, sorry, test procedures would not provide them to me at one time. Dr. yelled at me and was sent out of an office. Yeah, just go ahead and call our office or email us. We'll get you in for no problem. I appreciate so much what you do. Thank you so much, Tricia. Happy to see you.
What's going on? He's just about done.
I'm just about done. Okay, we'll close it here. Thank you guys.
My question.
Okay. And look forward to talking to you guys later.
So I'm out. Done.
Bye.
Bye now.
Bye, everybody.
Great talking to you.
Bye, everybody.
Bye now.
See you later. Bye-bye.
Bye.